So welcome. We're so happy you can join us today for this super duper power panel to talk about Medicare Advantage plans and other healthcare policy related issues. My name is Rebecca Cerise. I'm lucky enough to be your host tonight. For my day job, I do health advocacy work for the North Carolina Justice Center, largely focused on expanding Medicaid in our state. Yes, we still haven't done that here. The North Carolina Justice Center is a not-for-profit organization dedicated to eliminating poverty by addressing the issues that keep the cycle of poverty going. We do that through engagement work, advocacy, lobbying, and litigation. I'm also here as a proud founding member of the North Carolina Medicare for All Coalition, a volunteer-run group with over 43 diverse organizations and many individuals across North Carolina who are committed to fighting for a simple, efficient, quality, universal, single-payer Medicare for all healthcare system. We desperately need a healthcare system that puts people over profits, addresses racial health disparities, is prepared to address a public health crisis like the one we're facing with COVID-19, and offers affordable, quality healthcare to everyone. Sadly, that is not what we have today. So I wanted to share, just again, welcome to the people that are just coming in. Introduce yourselves in the chat. We have a packed schedule, so we're just sort of jumping in. This is also being broadcast live on the North Carolina Justice Center Facebook page, as well as the Medicare for All Facebook page, North Carolina Medicare for All Coalition Facebook page. So share it around. So I wanted to share a quick story from a nurse who contacted me the other day about a patient of hers that has a Medicare Advantage plan. She says, I have many stories, but the one that stands out to me is a woman with sarcoidosis status post-lung transplant who decompensated after signing up for one of the Advantage plans. In short, her plan did not have an in-network contract with the Duke Medical Center transplant service. So after years of care with them, she was told by schedulers and the finance department that she was not in network. As a result, she ran out of her meds and went into transplant failure within 6 months. Unfortunately, I, meaning the nurse, was not notified until she was in the ICU in failure. She did not understand the nuances of her new plan or not how healthcare works these days. Her story illustrates how one or two logistical complexities and barriers can cause an otherwise sick but stable person to disengage and decompensate. Despite trips to and from the hospital, ICU, and re-engagement with the Duke subspecialist, she ultimately died months later. So sadly, she is not alone. And it isn't just Advantage plans that lead to unnecessary suffering and death. It is our healthcare system in general. So to honor this patient and the many others who have died due to our cruel system, I would like to take a moment of silence. Thank you. So for folks who are just coming in, welcome. You could rename yourselves in the participant list and introduce yourselves in the chat. There's a lot of us. Thank you so much for coming. Just had done a few introductions, but moving right along because we have a packed schedule with our super duper power panel. We're going to launch the first poll of the evening. We want to sort of have some interaction with you all. The question is, what type of insurance do you have? Is the poll launched?
Yes, yeah. 33,
okay.
35 people have voted.
Okay, great. So obviously the choices are Medicare, Medicare Advantage, Medicaid, private insurance, none, not sure, other. So while we're voting, as you can see from the many choices in our poll, the current healthcare system that we have is an inefficient and complicated profit-based system that most people have trouble navigating. Which brings us to our program tonight. Open enrollment for Medicare starts on October 15th, and folks over 65, like my mom, got this easy to read 130-page booklet about her choices. Easy, right? Anyone can just read through this and understand perfectly. The more I do this work in healthcare policy, the more I realize just how absolutely crazy and complex our entire system is. And the saddest part is that it's really unnecessary. It does not have to be that way. We're the only major country on earth that has such a complicated and inefficient system, and we have terrible health outcomes because of it, which is just really a shame considering we're the richest country on earth and we spend almost double what other countries spend per capita on healthcare per person. And yet we also have 87 million to 90 million Americans or people in our country that are inadequately insured. So they're either uninsured or underinsured. So my mom got this booklet. I found it under our coffee table, not touched, not surprising. She's also being bombarded by ads for Medicare Advantage plans, robocalls, radio ads, you know, and so these are these private insurance plans that are allowed to use the Medicare name. Will these plans actually give seniors an advantage? We are lucky enough to have an incredible panel of experts who will answer that question and more. Now, I want to see if our first panelist, Senator Nina Turner, has signed on. I'm about 2 minutes early. I got through my introduction much quicker than I thought I would. So I'm not sure. Yes, I can address that again. So for some reason, we had like a little snafu in the technology, as happens, but you can rename yourself in the participants window to your actual name, although Stacey Borrello is wonderful. And it's great. It would be great to have so many Stacey Borrellos, but yes, you can rename yourself. Sorry about that. And please introduce yourself in the chat. We want to know where you're from. We have so many people joining us tonight, which is so exciting. I'm so happy that there are so many people that are interested in this topic and have come to listen to our, like I said, our amazing power panel of experts. Yes, thanks, Stacey. Maybe the real Stacey. Oh, it is the real Stacey. Yes, if you go to participants and then more, it should allow you to rename yourself. Yes, so we can, so yes, keep introducing yourselves in the chat and I will keep talking. So the idea came to me because to have this panel because like I said, we watch MSNBC sometimes. Literally every commercial break is a Medicare Advantage ad. And oh yeah, let's discuss poll results. We could do that. Thank you, Dana.
Can you see them, Rebecca?
I cannot. So Andy.
Sure. So we have 52% of attendees tonight are on Medicare. 22% are on Medicare Advantage, 2% on Medicaid, and 22% on private insurance. No one voted who is uninsured, but 2% are other, and no one voted not sure.
Thank you, everyone, for participating in that poll. And like I mentioned earlier, all the choices that we have in our poll just shows how bananas our healthcare system is. It's definitely not set up to actually help people stay healthy. So we are just waiting for our first panelist to come on. And again, anyone that is still named Stacey Borrello, you can change your name by going to the participants panel and clicking on the more, and it will allow you to rename yourself. And if you haven't already, please fill out in the chat, introduce yourself, where you're from. We're so happy to have you. wow, we have people from lots of different places. Efland, Wendell, Healthcare from Minnesota. Welcome, Minnesota. Charlotte, Asheville, Hillsborough, Durham, Lowell, Durham. Yes, I guess I can give bios of the speakers while we're waiting. Great idea. So Nina Turner Senator Nina Turner is going to be our first guest. So I am giddy to introduce our first panelist. She is a former Ohio State Senator and the host of her excellent podcast called Hello Somebody. She is one of the most powerful, brilliant, and inspiring leaders in our country today. She speaks truth to power. She is unbossed and unbought. And she understands that to deal with the issues of race and class that are tearing apart our society, we must get comfortable with being uncomfortable. I am beyond honored to introduce one of my political heroes. I don't know if she's on yet, though. Not yet. So I will not introduce her yet, and I will go on to introducing the other panelists. Thom Hartmann, who I just saw just joined us. Welcome, welcome. Thom is a four-time Project Censored award-winning New York Times bestselling author of 30 books in print and the #1 progressive talk show host in America for more than a decade. He is also one of the people who helped to keep me sane through the Bush and the Trump years with his wonderful show, which you could find on Free Speech TV, among other places. His latest book is The Hidden History of American Healthcare. It's a must read for anyone who cares about about healthcare justice. Just stop me, Andy, if Senator Turner comes in. Another one of our panelists in the power panel, Diane Archer. Diane Archer is founder of Just Care USA, an independent digital media hub that focuses on health and financial issues facing boomers and their parents. She is the past chair of the Board of Consumer Reports. Ms. Archer is the past president of the Medicare Rights Center, a national consumer service organization dedicated to ensuring that older and disabled Americans get the health care that they need. And lastly, but certainly not least, we have Dr. Steffie Woolhandler. She's a primary care doctor, a distinguished professor at the City University of New York's Hunter College, and a lecturer in medicine at Harvard Medical School, where she was formerly professor of medicine. She has published more than 200 journal articles, reviews, chapters, and books on health policy, and is a leading advocate of nonprofit national health insurance for the United States, including co-authoring a very important bankruptcy study, which she will touch on tonight. And in 1986, she co-founded Physicians for a National Health Program, also affectionately called PNHP, which is a fantastic organization that has incredible resources for people that are interested in Medicare for All. So I'll talk a little bit more about the Medicare for All Coalition while we're waiting. And if it's too much later, we'll have to go because I know Mr. Hartmann only has a set amount of time as well. The North Carolina Medicare for All Coalition is an amazing group of folks that really care about the health care situation in our country. Most of us have had our own personal experiences with this healthcare system that is designed not to actually give people care, but to make profits for insurance companies, for big pharma, for hospital systems, on and on. And sadly, it stays that way because the politicians that make our policy are, and I'm going to say it, they're bought. They're bought by these special interests, and therefore they do not actually pass policies that would help people, that would simplify our system, that would actually cost us less money. And so that is where we're at right now. which is really upsetting. But I will say this, it's actually, though, a very exciting time to be a health advocacy person. Frustrating, yes, but also exciting. There's a reconciliation package that is on the table right now that has really great provisions in there for healthcare, including a federal fix for the Medicaid coverage gap, which we briefly talked about, which we have a big problem with in North Carolina. That's on the table, which is exciting. And that came about from advocacy for a coalition that we're part of called Southerners for Medicaid Expansion. So advocacy can work. It wouldn't be on the table otherwise. Also, Medicare expansion is on the table, including expanding services to include vision, dental, and hearing. And of course, allow Medicare to negotiate drug prices, which mind-blowing that Medicare can't already do that, but that shows the power of these special interests in making policy for our country. Okay, Senator Turner is logging in now, so that is a great thing. Hopefully she will be there, but so anyway, really exciting time to be a health advocacy person. There's lots of opportunities to advocate. We're also coming up on elections, so we can be talking to people that are running for office about why they should run on Medicare for all, why they should fight for a single payer system that will save us money, address racial health disparities, keep us prepared for public health crises. It's really that simple. It's not simple, sadly, because of special interest money, but we need all the help we can get. We really, really do.
Just entered.
Yes, she is here. Wonderful, wonderful. Welcome, welcome, Senator Turner. I'm sure she's starting her, hopefully we'll get her unmuted in a moment. And I already did most of my intro, but I will start that with, I am beyond honored to introduce one of my political heroes, a self-proclaimed hell-raising humanitarian, which I am always aspiring to be as well, Senator Nina Turner.
Thank you, Rebecca, so very much. And to everybody, it's such a pleasure to be here. And I'm so glad you guys are keeping the fight. My apologies for being a tad bit late. I have back-to-back things happening right now. But, you know, it just brings me such great joy and encouragement to know that you all are keeping up the fight. And Rebecca, I love the sign behind you. I remember when we made those up, definitely Medicare for y'all. And, you know, when we're on a journey of this great significance, it's not going to happen overnight. We're going to keep pushing because we want it to happen. We're not going to just sit back and say, oh, well, it's not going to happen overnight. We're going to keep pushing. But in the push, we have to know that there were people before us pushing for this grand vision to ensure that everybody in our country had health care, that health care is not commodified. It should be an absolute human right, like it is in other industrialized nations. We are the only industrialized nation on the face of the earth that does not have universal health care. So if other countries can have it, why can't we? You know, they just increased the military budget. I'm sure some of y'all are old enough to remember they just did that a few weeks ago. But yet every time it comes to investing, making the requisite investments in people like us and other people all around this country, they always want to ask how much it costs. But they don't ask how much it costs when they're giving mega tax breaks to the ultra wealthy in this country. They don't ask how much it costs when they're putting more money in the Pentagon budget. So we cannot, we the collective, those of us conscious-minded, and I know those of you who are on this call are conscious-minded, we must never relent. We can't give up. We can't give out. And I know, and Rebecca, I know you know, and other leaders on this call, that when you're fighting for something like this, it gets daunting. Sometimes you want to throw your hands up. Sometimes you question your own sanity, you know, and all of those emotions and feelings are just fine. But what we cannot do is ever give up, give out, give in. Because this moment right here, this is time for us to seize this excellent opportunity to continue to push for Medicare for all. And I really do believe that as we push forward on the federal level, there are going to be some states. They're going to beat the federal government. When we think about universal health care in places like Canada, started in Saskatchewan first. Now, they were pushing for nationalized health care, but it started in one province first, and then it became a nationalized. What are you saying, Sister Turner? I'm saying this, that we must continue to push this nation forward in a more progressive direction. And then we got progressives all over the country doing the same thing in their respective states. We are going to get this moment. We're going to get it. You know, it reminds me of a quote from President Nelson Mandela. But before I get that, Rebecca, I got to thank Lauren, because Lauren, she sent me a text. She said, we waiting on you. They waiting on you. So let me shout out Lauren. I want to say this. I was just in the UK. And I was invited by by a labor union, the CWU, and they represent the postal workers in UK. And also a progressive magazine, Tribune, which is similar to our Jacobin magazine here in the States. They have universal health care over there. But you know what? They're fighting to preserve it and to strengthen it, because there are forces over there that, even though they have nationalized health care, there are forces over there that's trying to take it away, trying to scale it back, trying to privatize it here, privatize it there. See, when you are fighting for justice, when you are fighting for something that is this magnificent, just know that the forces that are mounted up on the other side, they never gonna give in, give out. So we can't ever give in and give out. And so I tell that story just to say that in this nation, that once we get it, because we're gonna get it, we can't ever stop fighting to preserve it. The commodification of healthcare is wrong. It is rotten. It causes people to die. The fact that right now we're begging two senators in particular, but there's others, I think, who hiding behind them, but that's another story, that within Medicare right now, Senator Sanders and others pushing to expand Medicare so that it can provide dental and vision and hearing for our more seasoned people in this nation, getting pushed back. And then to try to allow Medicare to be able to negotiate for lower prescription drug prices. And you got folks like Senator Sinema and Senator Joe Manchin trying to even stop that. So we are in a pivotal moment in our nation's history and in the world's history. And so those of us who are willing to give it our all cannot relent 1 inch. Because although we are not perfect, although our movement is not perfect, what we are fighting for is humanity. That is what we're fighting for. Nobody should die because they don't have health care. Nobody. You know, a good friend of mine just told a story of a local mayor here in Cuyahoga County who had a relative who had an emergency that was not related to COVID. But because hospitals are overwhelmed with COVID, they couldn't see him. And guess what? He passed away. We have a system that does not work. And a lot of doctors, the doctors on our side, they call it sick care. That's what it is in the United States of America, sick care. But we can afford to do a new thing politically, economically, and socially. We are the wealthiest country on the face of the earth. And as the wealthiest country on the face of the earth, we must not accept mediocrity. We must not accept the crumbs from the master's table. We must continue to fight. And you know what? Them folks in Congress, and Rebecca, I'm about to end this. You got me all wound up. Let me tell you something. Them folks in Congress got taxpayer-sponsored health care. So what we gonna make a demand on them? If you don't believe in universal health care, if you don't believe in Medicare for all, then give up your taxpayer-sponsored health care. Why don't you? We're paying the health care costs of some people who don't want you to have health care, your mother, your father to have health care, your sons and daughters to have health care. And there is something wrong with that. But we're not going to give up. We're not going to give in. We're not going to give out. We are going to not only keep the faith, but we are going to keep the fight. We're going to do what my dear friend Michael Render, a.k.a. Killer Mike, once said. We are going to plot. We are going to plan. We are going to strategize, mobilize, organize, mobilize. And then we're going to realize, I threw that in there, we're going to realize this. So just as the generations that fought for Medicare as it exists today, don't think they weren't naysayers telling them they were wrong. They called Medicare as it exists right now today socialized medicine, said it was going to ruin the United States of America. Now I double dog dare you to take Medicare as it exists today away from any of our elders. They will rise up and revolt in this country because it works. So we want to enhance it and expand it so that everybody in this country can have it, entitled to it, must have it. Okay, so the three bones. So which bone, jawbone, backbone? That's it. I want you to hold on to my grandmother's words. The wishbone is for hoping and praying because hope is our motivator and the dream is the driver. The jawbone is so that we lift our voices and speak truth to power like you are doing here tonight, continuing to be on the front lines and continuing to challenge the people who we gave our power to. We are on the right side of history. But Grandma said the most important bone of them all, the supercalifragilistic expialidocious bone, is the backbone. And the backbone is going to keep us standing through all of our trials and our tribulations. We can't have a testimony without a test. And we are being tested right now to determine whether or not we got courage enough, conviction enough, tenacity enough, and fight enough to do what is right in our own time. So we're going to take my grandmother's three bones, the wishbone, the jawbone, the backbone. We're going to keep on pushing. And finally, on grandma's bones, this is my last point. President Nelson Mandela once said this: it always seems impossible until it is done. See, there was a time when they said that my ancestors wouldn't be free until it was done. There was a time in this country where the status quo told women they weren't going to get the right to vote until it was done. It was a time in this country where Medicare as it exists right now did not exist until it was done. It was a time when we didn't have unemployment insurance in this country, and then it was done. It was time that we didn't have a minimum wage, and then it was done, even though we need to increase it. Y'all see where I'm going? Every generation has freedom fighters like us. So we gonna keep fighting to make the impossible possible. I love you all. Thank you so much for what you do. Rebecca, thank you for inviting me. To all of the sisters, brothers, and family and friends who are on the leadership team and who are on this call, never relent and never give up. We are going to see victory, but we got to keep pushing. I love all of y'all.
Thank you so much, Senator Turner. Thanks for taking time and squeezing us between your lots of other obligations. We are so thankful.
Thank you.
Have a good rest of your evening.
Thank you. Good night. Going to the next event, but I love you guys. Please keep the faith and keep the fight.
Well, thank you for your inspiration.
Thank you.
Wonderful. So I'm going to just throw it over to Thom Hartmann right now because I know he's on a tight schedule as well. Mr. Hartmann, welcome. Thank you so much for being here. I'm sorry about the delay.
Oh, it's all good. Hey, Rebecca, thank you so much. And hello to everybody. It is so cool that you're all here and we're talking about this. I wanted to talk about the Medicare Advantage scam. It's kind of my topic here tonight. And point out that Medicare Advantage is not Medicare. In fact, Medicare Advantage was not even envisioned when Medicare was passed in 1965 and put into place in 1966. At that time, there was a provision built into Medicare that would allow health insurance companies to insure seniors, but it was for the weird exceptions where people would fall through the cracks. You know, like there are some federal workers, for example, or some, like railroad employees, for example, they don't pay into Social Security. So there's a whole separate pension program for them. It's kind of the same thing with Medicare. But what happened in the early 2000s, I don't recall if it was 2003 or 2005. Yeah, it's 2003. George W. Bush, who had spent his entire political career campaigning on privatizing Medicare and Social Security, back in 1978, he unsuccessfully ran for the House of Representatives from Texas on the single platform of privatizing Medicare and Social Security. And after he got reelected in 2004, in 2005, he came back and said, I've got the political capital. I'm going to do what I came here to do. And he started what turned into about a 13-city tour. It was supposed to be a 25-city tour, traveling around America in early 2005, pitching the idea that Social Security should be turned over to the Wall Street banks, that it should be privatized. The more he did this, the more cities he visited, the more unpopular the idea became. And finally, he just gave up on it about the middle of 2005, said screw it, and went home. But, continued with what he was doing. But 2 years earlier, he had taken a big bite out of Medicare. And the way he did it was taking that Medicare Part C provision and, for filling in the cracks, as it were, and created a whole brand new hole in Medicare where private for-profit insurance companies could come in and offer health insurance to people over 65 and be reimbursed for the process of doing that by the Medicare administration out of the Medicare trust fund, out of the money that, we've paid into Medicare all our lives. And it has turned into a giant, absolute scam on the government, and also in many cases, in fact, I would argue in most cases, on the people who are in these Medicare Advantage plans. So this was, which is, by the way, now about 40% of all people who think they're on Medicare are actually on private health insurance called Medicare Advantage. And just to give you a few details on how this is playing out, Medicare Advantage, one of the things that Medicare Advantage plans very often do is they say, we'll send a private nurse out to your house or a physician's assistant to give you a checkup, when you first signed up with us. The reason they're doing this is because if they can upcode you, the federal government reimburses them, it's not fee for service. It's not like, you have an appendectomy and the government says, oh, well, that's $5,000, here's $5,000. Instead, the Medicare Advantage insurance companies say to the government, we've got 1 million people who have this risk factor. And if, and then the government says, okay, oh, you've got 1 million people with heart disease, heart failure. So, okay, that means that you get this pile of money. You got, 500,000 people with, whatever, you get this pile of money, whether they actually provide the service or not. So, for example, a little tiny tick on an EKG that might not even affect a person for decades, or in all probability will never affect them, is frequently coded as heart failure. Medicare Advantage companies, the insurance companies, get a huge pile of money. The patient, the individual, the insured person, doesn't even know they've been coded and doesn't get any services for this because it's an inconsequential thing. Same thing with depression. The nurse will come to the house and say, you ever feel depressed? Well, yeah, from time to time. Has it ever lasted more than 2 weeks? Yeah, I suppose. I had a tough time when my dad died. Oh, okay, they write that down. A major depression is considered, a transient depression for Medicare purposes, or for these purposes, these reimbursement purposes, is considered less than 2 weeks. It's a doctor's prescription and a week of Valium or something. More than 2 weeks, it's considered a major depressive episode, a lifelong problem, and massive amounts of money get shoveled to the insurance companies, even though, again, the person is getting no services. As a consequence of this, this is from an in-depth investigative report. It was done by the Center for Public Integrity in 2014. And what they found was that risk scores of Medicare Advantage patients in 1,000 counties nationwide cost taxpayers $36 billion more than it would have cost to provide the same services to those people through traditional Medicare. In 200 counties, an additional 200 counties, it would have cost, we paid them 25% more than Medicare would have cost. So they just, they were taking money to the bank. The Centers for Medicare Services, the government itself, did an evaluation of this, and they determined that these faulty risk scores triggered nearly $70 billion. This is just from 2008 to 2013, $70 billion in what the Center for Medicare Services do, quote, improper payments to the Medicare Advantage companies. $70 billion. They decided not to seek reimbursement for any of it. It was like, big deal. What can we do? Then when the Inspector General for Health and Human Services, which oversees Medicare, did an audit of only 6 out of some 300 plans out there. They audited 6 of them, and they found that just those 6 companies, and this is a quote from the Inspector General's report, had been overpaid by an estimated $650 million for that 1 year, end quote. They settled by having those 6 companies in aggregate reimburse Medicare with $1.3 million for a $650 million overcharge. The next year, going forward, Medicare Services decided that they were only going to audit 30 plans a year. And if you were to audit only 30 plans, it would take 15 years to review all the Medicare contracts that were in force. And that's just for 1 year's activity. So it's obviously not happening. This is from this is from a letter from Sherrod Brown, Senator Sherrod Brown, to Trump's CMS Administrator, Seema Verma. He said, the recent HHS payment accuracy report exposes that taxpayers have overpaid Medicare Advantage plans by more than $30 billion just over the last 3 years. Again, these companies are just taking this money to the bank, and they're using it to buy ads on TV to get Joe Namath to tell you how wonderful you can sign up for Medicare Advantage. People using Medicare Advantage, this is from an NBER study. People with Medicare Advantage got 15% fewer colon cancer screenings, 24% fewer diagnostic tests, 38% fewer flu shots. In other words, you just don't get the services. And by the way, if you get really sick, well, I'll get to that in just a second. Well, in fact, I'll just lay it out. I had a friend in New York. I call him Sam in this article that I wrote about it, and there's the chapter about this called the Medicare Advantage scam in my book, The Hidden History of American Healthcare. And I had not seen Sam or even talked to him since the 1970s. We used to hang out in Greenwich Village in New York City back in the day. But, I knew him pretty well back then. And we have a mutual friend, Jerry, who lives in New York. And Jerry was telling me while I was writing the book, just coincidentally, I was ranting at Jerry about Medicare. And he says, oh, I got to tell you what happened to Sam. And I'm like, what? And he says, well, he turned 65 and he went online to sign up for Medicare and he couldn't figure out, it was just too confusing. And so he figured he'd just deal with it sometime later on in the year. Then a month or so later, it had been getting harder and harder and harder for him to urinate. And so he finally went to one of these doc in the box places, where you pay $50 and see a doctor. And it was run by one of these big hospital groups. And they pulled blood and did a PSA test and discovered that his PSA was like in the hundreds. It was so high that he not only had prostate cancer, but it had probably already escaped his prostate, which is the second leading cause of death for men in the United States. So as he was checking out of the doctor's office, they said, you don't have any insurance. We can sign you up for a Medicare Advantage plan that's offered by our hospital group. And he was like, okay, cool. And they're like, it's free. And we'll give you insurance right now. And he was like, okay, cool. So then he goes back home and he starts looking around for a good cancer doctor who specializes in prostate cancer. He's got this Medicare Advantage plan. And he finds that the best, cancer doc he lives in New York City, the best cancer docs in the world for prostate cancer are at Sloan Kettering Memorial Cancer Center in New York. So he makes an appointment, says, I got Medicare. They're like, fine. A few weeks later, a month later, he goes in for his appointment and they're like, oh, you've got Medicare Advantage. We're not in this plan. So we can't see you. I'm sorry. So then he goes and he really wants to see somebody who's an expert at this stuff. I mean, he's got metastatic prostate cancer. So then he goes back to the Medicare Advantage provider and says, you don't have any cancer specialists in New York City that deal with prostate cancer. And I want out of the program. And so they're like, okay, well, it's been less than a year. You can leave the program. So he signs up for regular Medicare, makes his appointment with Sloan Kettering, shows up again. And they're like, yeah, but what about the 20%? Do you have a Medigap policy? And this is what Sam discovers, that when you first turn 65 and you sign up for Medicare, normal Medicare, and you sign up for a Medigap policy that fills in that 20% hole, they can't turn you down if you're already sick. But if you sign up for Medicare Advantage first, and then decide, hey, the Medicare Advantage provider, the insurance company, is playing these old insurance company games with me, making me jump through hoops, making me get pre-approval for every doctor visit, making me pay copays and deductibles. And, I just don't want this anymore. I want to go back to regular Medicare. After that, if you are sick, they can refuse to insure you. Medicare won't refuse you, but that 20% gap, the Medigap policies, they will refuse to insure you. And at the time that I was writing the book, that was in November of last year, Sam had still not seen a doctor. I mean, that is how bad it was. And I talked to Jerry recently, and Sam ended up seeing just a regular doctor that he could pay for out of pocket, and who told him he's probably going to die. I mean, it's a really, really bad situation. So the last thing that I would add with regard to this whole Medicare Advantage scam, and I'm telling you, it's time to end it, although it's growing like a weed, is that it wasn't just put into place to make money for these companies. It wasn't just George W. Bush and the Republicans and some Democrats pushing this thing through in 2003 so that the health insurance companies could make money. It was put into place to privatize Medicare. That's why there's Medicare Advantage. And once they hit more than 50% of all the people on Medicare in the country being on Medicare Advantage, it becomes the default plan. And then you're going to hear Republicans say, oh, you want Medicare for all? That's cool. We got it. We've got it. Here you go. It's Medicare. It's called Medicare Advantage, but everybody in America is welcome to sign up for Medicare Advantage. And we'll be right back to the same old health insurance plans that we always had with the same old rip-off health insurance companies. So we've got to get active on this and raise some serious hell about it. Thank you. Is that okay, Rebecca?
That was great. Thank you so much.
Okay. Thank you all.
Some stuff in the chat. Is there any way you can send some of those resources?
I can't hear you. Sorry. Sorry. Say that again.
Is there any way you can send some of those resources?
Everything that I just shared with you is from a chapter in The Hidden History of American Healthcare, complete with footnotes. The chapter is titled The Advantage War Against Medicare. It starts on page 28. All the stats and everything are in there. Okay.
Wonderful. Thank you so much. We appreciate you coming on. Thanks again. Have a great rest of your night.
Thank you. You too, and have a great conference. Thanks so much for inviting me. It's a real honor to be here. Good night.
So are people having a hard time hearing me? Okay, hold on.
Okay, can people hear me now?
Yes,
Better?
that's good.
Okay, great. Okay, I can take a breath now that the two folks that had to get out of here at an exact time have gone off. So thanks for sitting with us through the speed through of Senator Turner and Thom Hartmann. We have great speakers coming up. And Diane Archer and Steffie Woolhandler will actually be taking a few questions at the end, so you can start putting questions in the chat if you'd like. And we're going to launch our second poll. Andy? And just tell me when it's up, or you can read it.
Just launched.
Okay.
So the question is, do you believe that insurance for seniors should include dental, hearing, and vision?
Very easy yes or no poll on this one. So while we'll get the results of that poll after, if Diane Archer is here and ready to go, we would love to hear from you. And I am going to get your PowerPoint up and ready to go.
Thank you, Rebecca. Thanks for having me. It's really great to be here. And I have a few slides to share with you. And basically, I'm going to be picking up where Thom left off and taking a deeper dive in some of the topics that he focused on. I'm going to focus on, next slide, please. On 4 serious problems with Medicare Advantage: their high costs, their questionable quality, their unreliability, and their lack of accountability. And I know Steffie's going to follow up with some hard numbers. After 35 years of private insurers and Medicare, there's still no way to assess quality and good reason to worry about it. Medicare Advantage is more costly than traditional Medicare and brings with it hundreds of billions of dollars in administrative waste. It's unreliable. People can't make a meaningful choice among Medicare Advantage plans because there's no way to know in advance the administrative and financial barriers you'll face when you need costly care. And government can't monitor the behavior of these plans effectively, much less deter their bad behavior. Next slide. If a picture is worth 1,000 words, I think you're looking here up. I can't see them all, but there are 4 pictures. You're looking at 4,000 words, which I'm going to condense a little. On quality, you're playing a game of Russian roulette. So long as you're healthy, you're fine. If you get sick, it's not clear you'll get the care you need. On the cost front, the Medicare Advantage plans are paid upfront, and they're looking to get as much as they can and hold on to as much of it as possible. That's not a recipe for good healthcare coverage. What can you count on from a reliability perspective? Almost nothing. Plans come and go, change their policies and practices all the time. And what do they have up their sleeves? The little we know about denial rates, mortality rates, and disenrollment rates is scary. And there's so much more we don't know because they're unaccountable. Yet enrollment is growing fast and furiously, largely because these plans are doing a great job of leading people to believe they offer more than traditional Medicare for less. Next slide, please. To take a deeper dive into these issues on the quality front, Medicare Advantage is concerning for several reasons. There should be a bunch more text coming up. Yeah, great. First, the way the government pays them. They receive a fixed amount upfront, regardless of the cost of the care they deliver, which creates an incentive for them to find as many ways as possible to avoid paying for costly care. Large employers don't do that. Other countries with private insurers don't do that because it makes no sense. Second, the government structures Medicare Advantage contracts to give them a lot of control, too much control over the care they cover. They decide when to pay for care and what to pay for. They can come between patients and doctors. They can override the decisions of treating physicians as they please. They also get to choose the doctors in their network. There's no requirement that they include centers of excellence, as Thom was saying. They don't need to include Sloan Kettering, or that they make it easy for people to get care wherever they happen to be. They don't have to disclose data on the care they cover for people with costly conditions, and they don't. We should know which Medicare Advantage plans, if any, deliver the best cancer and stroke care, but we have no clue. Rather, we know that lack of good specialists and large out-of-pocket costs for this care force people to forgo it or to disenroll. Next slide. On the cost front, the cost in Medicare Advantage, both for taxpayers and for people with Medicare, is equally, if not more concerning than the quality issues. The government gives Medicare Advantage plans all the tools they need to upcharge taxpayers and in the process drive up costs for people with Medicare. They're paid a fixed rate benchmarked to traditional Medicare, but they're paid more, as Thom was saying, when enrollees have multiple diagnoses, regardless of whether these enrollees use more healthcare services. So the MA plans invest in hiring doctors and agencies to find as many diagnoses as possible for their enrollees, driving up taxpayer costs inappropriately. This is called upcoding. As a result of this upcoding, Medicare Advantage plans are projected to cost as much as $355 billion more than traditional Medicare over the next 10 years, and they're draining the Medicare Trust Fund and increasing Part B premiums. How do they do that? Whenever Medicare spending goes up, so do premiums. People with Medicare pay 25% of the cost of Part B services and premiums. One other cost I want to flag. Medicare Advantage plans have never disclosed data showing average out-of-pocket costs for their enrollees. What we know from the Kaiser Family Foundation is that these costs present a barrier to care for many of their members, particularly those with modest incomes and serious health conditions. Next slide, please. On to reliability. No one should think they can pick a Medicare Advantage plan that meets their needs. It's not clear that any of them would, but to the extent that some are better than others, there's not enough information. And even if there were more, so much can change at any time. There are no guarantees. It's fair to say that people who are healthy and have limited incomes spend less on their coverage than they would in traditional Medicare, because Medicare Advantage, unlike traditional Medicare, has an out-of-pocket cap. With traditional Medicare, you need to buy supplemental insurance to protect yourself from financial risk, and that can easily cost $2,500 a year or more. But Medicare Advantage presents a big financial barrier to care for people with costly conditions. The out-of-pocket cap can be as high as $7,550 this year. And if you can't get the care you need, out-of-network costs can be enormous. That's why people who develop complex conditions leave and switch back to traditional Medicare, if they can, at disproportionately high rates. Next slide, please. On to the lack of accountability in Medicare Advantage. As structured, the government really can't protect enrollees. There's no way to monitor Medicare Advantage plans effectively and hold them to account for their bad acts. After 35 years, MedPAC doesn't have the information it's supposed to have to assess quality, even though the Medicare Advantage plans have been required to provide complete and accurate information for years. And that's seemingly of no consequence to government. These plans just continue on their merry way. There's virtually no information about Medicare Advantage plans that would help enrollees distinguish among them in a meaningful way. We know more about the restaurants we go to. We can see what's on the menu and what the food costs. We have little clue with Medicare Advantage. And people think that Medicare Advantage plans all offer the same coverage since they all must offer the same Medicare benefits, but no siree. People with the same benefits might have very different experiences getting coverage for the services they need. Each Medicare Advantage plan gets to decide when to second guess treating physicians and deny care. They decide the services they'll pay for. According to the Office of the Inspector General, some of them have high levels of inappropriate denials. Although, guess what? We don't know which. Next slide, please. Okay, so the key measure of good health insurance is whether it meets the needs of people with costly and complex conditions. How troubling is Medicare Advantage? Well, one NBER study found high mortality rates in some Medicare Advantage plans. The study found that CMS could save thousands of lives by terminating the contracts of Medicare Advantage plans with the highest mortality rates. But those contracts continue. What do? What will get Congress to do away with Medicare Advantage, or at least rein the Medicare Advantage plans in? Next slide, please. Right now, Congress is focused on regulating drug prices, which is absolutely critical, and adding dental, vision, and hearing benefits to Medicare, which is equally critical. But it's not focused on everything that it needs to be focused on. It's certainly not focused on Medicare for all the way it should be. And it's not focused on making sure that Medicare Advantage plans are not reaping the hundreds of billions of dollars in overpayments. And it's not focused on ensuring that traditional Medicare doesn't wither on the vine. Right now, Congress is literally empowering and enriching the insurers offering Medicare Advantage, even though traditional Medicare is more cost effective and doesn't make people go through hoops to get needed care. Traditional Medicare needs an out-of-pocket cap at a minimum if Congress wants to give people the choice of traditional Medicare. The cost of supplemental coverage is prohibitive for most people. My fear is that as much as dental, vision, and hearing benefits are needed, and they really are needed, if those benefits are not designed well, they're likely to drive up the cost of supplemental coverage in traditional Medicare and push more people into Medicare Advantage. Final slide, please. So what's to be done right now? We need to make traditional Medicare much stronger so that it's a meaningful choice for people. And Congress really needs to completely restructure Medicare Advantage or just throw it out. It needs to function much more like a fiscal intermediary if it's going to work at all, like the private plans in Europe. And they need to be publicly accountable at the very least. That's it. Thank you.
Thank you so much, Diane. That was fantastic and troubling. All at the same time. I think, you know, so many folks just see the free services, free dental that they say that they're going to have and don't realize that on the back end to the taxpayer, it's actually not saving money. But I know, and several people have brought it up in the chat, that in some cases, you know, this is the most affordable. Medicare Advantage plans are the most affordable for folks in particular with low income. So it becomes a, you know, a very difficult decision for people to make. So,
They're affordable. They're more affordable on the front end, but they're much less affordable on the back end when you need care. And that's what insurance is about.
Exactly. Thank you. Would we be able to share your slides with folks?
Absolutely.
Okay, wonderful. We have to get some poll results. Andy, what did people say about whether seniors should be able to get dental, hearing, and vision?
100% yes. Everyone voted yes for that.
Okay, wonderful. And thank you, Steffie Woolhandler, for waiting. If you're ready to go, you're up.
Well, thank you. Let me get this screen sharing going. Okay, I hope everyone can see the screen now. Everyone just shake your head no if I missed something. Okay. Okay, well, I promised to talk just a little bit about the issue of medical bankruptcy, because I did work on medical bankruptcy for years with now Senator Elizabeth Warren. We were both at Harvard at the time. She was at the law school and I was at the med school. And we wrote several studies showing that about half of all personal bankruptcy in the United States were due, at least in part, to medical illness or medical bills. And you probably know about this because they were actually quite a bit in the news, that more than half of all bankruptcies are medical. People are less familiar with this, which was also a finding in our study, which is that most people entering medical bankruptcy in this country had some coverage, at least when they first got ill. Okay. Now at the bottom, you'll see that 22% of people were uninsured. So they faced bankruptcy at about double the rates you'd expect, right? They were more likely than insured people to be bankrupted. But the majority of the total folks who were bankrupted actually did have insurance. And that has to do with co-payments and deductibles, which are very prominent in private insurance. But as Diane was pointing out, unfortunately, it can be quite expensive in traditional Medicare as well if you can't afford the Medigap. So, just want to point out that the affordability of healthcare is a very serious problem, whether or not you have health insurance. I want to switch, and actually just some more data. When this data first came out, we got a lot of pushback from the academic community. Oh, could this really be true? This is so shocking. You must have done something wrong. But just about 3 weeks ago, there was a study in the JAMA showing that the majority of all debts in the United States sent to collections in this year, the majority of all debts are in fact medical at this point. So the cost of medical care is like a major financial problem, sometimes for many families, sometimes leading to bankruptcy. Now, Medicare Advantage, which is which I'm calling Medicare HMO. The reason I'm calling it Medicare HMO is that this is an older slide, or it goes back a long way. And initially, these Medicare private plans were called Medicare HMOs. And then they were called Medicare Plus Choice, and now they're called Medicare Advantage. But they've been around for a while. They tend to be, enroll a lot of people rather rapidly during Republican administrations, slow down a little bit during Democratic administrations. But lately, the enrollment has just been going through the roof. And sorry about that. Currently, more than half of all the total business of private insurance companies in the United States comes from the government as either Medicare Advantage premiums that the federal government pays on behalf of seniors, or as Medicaid managed care premiums. So, now that private insurance through an employer, private insurance through an individual plan is a minority of the total business of the U.S. private health insurance industry. Now, this is some work done by the Government Accountability Office, and looking at the overhead in Medicare Advantage. And it actually has been reproduced more recently, but I like to quote the GAO because they're such a definitive source. But the overhead in traditional Medicare tends to run about 2%. It's very cheap to administer traditional Medicare because you're automatically enrolled at age 65. They use a Social Security system. to keep track of you, collect your Part B premiums, or have your Social Security checks. It's a very efficient system. And also there's no prior authorization. There's no referrals in traditional Medicare. You just go to any doctor who accepts your Medicare. Medicare Advantage has a much higher overhead, at least 14%. So, many-fold higher than the overhead and paperwork costs associated with traditional Medicare. Now, despite this, you would think, well, wow, why can't traditional Medicare compete if they're so efficient and Medicare Advantage isn't? Well, that doesn't look very good, does it? It turns out that they can compete because, sorry about the writing there, but they compete despite Medicare's lower overhead. Medicare Advantage can outcompete traditional Medicare in 3 ways, and it's cherry picking, which is, selecting healthier than average seniors, lemon dropping, getting rid of folks who are high cost, and upcoding / overdiagnosis. I put those together because that's really one concept. You've heard a little of this from the previous speakers, but I'm going to show you some of the data about what we're talking about. Now, it turns out that a handful of people, less than 20% of people each year, account for more than 80% of costs. So if you had the bad luck of being hospitalized last year, you were probably in those top 2 deciles of spending. If you're lucky, you were down at the bottom. But what this slide is showing is if you take the population and break them down into deciles, 10%, next 10%, next 10%, based on their healthcare spending, the folks in the top 2 deciles, the ones who were sick last year, account for more than 80% of all spending. So I call it the 20-80 rule. 20% of people account for 80% of spending. But that means if you're an insurance company or particularly a Medicare Advantage plan, you want to recruit those people down at the left-hand side of this graph who didn't use any care or used a tiny little bit of care. And those are the folks you want to cherry pick. And then the ones in the top 2 deciles there that are accounting for more than 80% of care, you want to lemon drop them. That is, if they get enrolled in your plan, you want to figure out a way to get rid of them. And initially, when the Medicare HMOs, this privatized Medicare first came in the 80s, they mostly cherry picked, okay? But it has become more and more difficult to cherry pick. So now the plans mostly work by lemon dropping and forcing sick people out, okay? And upcoding, which we're going to get to. So lemon dropping, forcing you out, but upcoding. Nonetheless, there's still some cherry picking going on. This is some work from Kaiser looking at diabetic patients, for instance, who stayed in Medicare, traditional Medicare, versus diabetic patients who switched. And somehow or other, they managed to go into a group of diabetics and cherry pick the ones who had lower costs in the year before they switched out. So look at the year before the switch, folks who got recruited into Medicare Advantage had lower spending than other diabetics. And this was true when you looked in asthma, when you looked in depression. They were able to cherry pick contingent on diagnosis, cherry pick of people within a diagnostic category and find the least costly folks. And I'm going to get back to how you might do that in just a minute. But I also want to talk about the lemon dropping. And one of the really big ways you lemon drop is to make it really inconvenient and really expensive for very sick people to stay in your plan. And the story Thom was telling about, yeah, you're really sick and you want to go to Sloan Kettering. And, actually community hospitals, a good community hospital can do a pretty good job with cancer. But if you have a rare or surgically complex cancer, you need to be in a cancer center, okay? So one thing would be just not letting you into Sloan Kettering and not signing up with cancer centers, not signing up with tertiary care centers that, people with really complicated illness may need. But this is a real classic Medicare Advantage trick. They just charge you a huge copay, a co-insurance for your chemo. Now, co-insurance is not a copay. Co-insurance means you pay 1% of the bill. So if you want to get rid of people requiring $100,000 chemo a year, then you make them pay 20% co-insurance, meaning they have to pay $20,000 a year. And Medicare Advantage plans, essentially all of them now require this 20% co-insurance for chemo, just to push their expensive cancer patients out. Similarly, if you have high care needs, you're disabled, you're just much more likely to be switched out of Medicare Advantage and back to fee-for-service. Okay, so people who are in Medicare Advantage, they develop high needs, particularly if they're poor, they're much more likely to get pushed out of the Medicare Advantage plan than people who are low needs and non-poor. So again, lemon dropping. If you're sick, you get pushed out. They won't let you go to Sloan Kettering. They won't pay. They make you pay 20% of your chemo bill, $20,000 a year. They push you out somehow. There's a whole lot of data showing this. I had another 5 slides showing recent studies looking at different development of different serious conditions and people being pushed out of Medicare Advantage. But I want to talk about upcoding because it sounds like a totally boring topic, you know. The upcode, how could it, well, it could be more boring, but upcoding is really a mechanism that is destroying Medicare because it allows Medicare Advantage to get overpaid year after year after year, sapping money out of traditional Medicare. So there's no money left for, you know, for the eyeglasses and no money left for dental or for hearing. And, you know, they're not the only people sapping money out. Obviously, the pharma has been taking huge amounts of profits out of the Medicare program. And there was a plan to try to rein those in that failed. But now we're really facing this dilemma where the Democrats have promised the American people that they were going to add eyeglasses and dental and hearing benefits to traditional Medicare. They promised the Medicaid non-expansion states that the federal government was going to take over the full cost of Medicaid and allow Medicaid expansion in the non-expansion states like North Carolina. And now, of course, farmers stopped the reform that was going to reduce their prices and use that money to support Medicare and Medicaid. But we also have this problem with Medicare Advantage, just draining money year after year after year. That means that we can't actually have the good stuff like complete eye, hearing, and dental care within Medicare or expand Medicaid. But this is actually some upcoding work done by Rick Kronick. And what you see in purple is the way Medicare Advantage plan is paid is based on a risk score, which is just a list of diagnoses that the Medicare Advantage plan assigns to a patient. Traditional fee-for-service Medicare is not paid that way. You can generate a risk score, but that's not the way the doctors are paid, okay? So if you look at traditional, fee-for-service Medicare, that purple line, the risk score has creeped up a little bit. Maybe people are getting sicker. Maybe there's a little bit of upcoding because unlike the doctors, the hospitals might have an incentive to upcode. But, there hasn't really been that much increase in the risk score of senior citizens in Medicare. But look what happened with Medicare Advantage. They started out with this group that looked really healthier. And then they just got on paper, the risk score went up and up and up. So that the premium that the taxpayer pays goes up and up and up because these people on paper look much sicker. And this is an extremely large amount of money that gets overpaid to these plans. And this is just some data from MedPAC. This is the official Medicare Payment Advisory Commission to Congress. They're bipartisan. They're half Republicans and half Democrats. They're not a liberal organization, but every single year they come to Congress and say, you're overpaying Medicare Advantage. Some years are overpaying them by 18%. Some years are overpaying them by 5%. But year upon year, you're overpaying them, draining money out of traditional Medicare that could be used to improve benefits for seniors. And now, what do they do with that money? Well, they do take a small share of the extra taxpayers' premiums to give some extra benefits to seniors. You know, they do, I think most Medicare Advantage plans, for instance, give you reading glasses. The co-payments can be a little lower. So, you know, up front, things look a little better. But as Diane pointed out, if you really get sick, it's more expensive to have Medicare Advantage. But, you know, for the average patient who's not very sick or moderately sick, in fact, you know, the Medicare Advantage plans have overcharged the taxpayers. They kick a little bit back to you as extra benefits. Okay. However, overall, there's really a lot of overpayment going on, and this is really one of the best studies to come out of out on this. And what they did is they said, well, we're going to risk adjust not based on these diagnoses that the Medicare Advantage plans report to us. We're going to risk adjust based on the mortality over the long run. So if someone is an older person is very sick, they're going to have a high mortality on average. If they're not very sick, they've got a lower mortality. So we can use that to adjust, but you know, you need to observe this over a period of years. And when you do that kind of risk adjustment that does not rely on what the Medicare Advantage plan, you know, wrote about the diagnoses, this is what the cost comparisons look like between traditional Medicare and Medicare Advantage. And this is in dollars per member per month in 2010 dollars. Okay. But in traditional Medicare, as I said earlier, you know, only that little tiny strip at the top is the overhead. That's the 2% overhead, or about $14 at the time. In the Medicare Advantage programs, payments for care were much lower. You know, the blue part of this, they're only $642 versus $706. So they pay less to the doctors, the hospitals, the Sloan Kettering, et cetera. And the overhead, but the overhead is so high at $125 a month that the cost to the taxpayers goes up. So the taxpayers are paying more, the patients are receiving less care, the insurance company's pocketing, you know, at this point, $125 a month. Now, that was the situation previously, but as Diane was talking about, there's a new kid on the block, which is incorporating primary care practices into Medicare Advantage and basically turning primary care practices into what I call coding shops, that their raison d'etre, their way of making money is upcoding like crazy. And I've been a primary care doctor all my life. I want to tell you that there's no way plain old primary care is making money in the U.S. healthcare system through legitimate means. You know, all of my life I was told by my department, oh, you know, the specialists are subsidizing you as primary care because we can't really even break even on primary care. I don't know if that's quite true, but nobody ever thought we could make, you know, that we made much money. And yet these primary care groups that are affiliated with Medicare Advantage, that contract with Medicare Advantage, are wildly profitable, as we can see from their valuation, right? Like what the stock market's setting as their value. So the current used to be when you bought like a practice or an insurance company, you would pay about between $4,000 and $10,000 per covered life, per enrolled patient, right? All of a sudden, the cost per covered life in a primary care practice is $87,000 a year, $87,000, right? So if you look at Oak Street Medical, so I don't know if you live in an area that has Oak Street Medical, but they're very big in Philadelphia area, I guess. But they cover about 90,000 patients. They have a market valuation of $13 billion, which means the market valuation is $196,000 per covered life, with similar amounts, you know, for some of these other companies. Some are privately held and some are publicly held. That's the mechanism at the end, just describes different publicly held means they sell stock. Privately held means they're for profit, but they don't sell stock. But if you look at these companies, why are they so damn valuable? Well, that's because they are literally upcoding factories. They see the patient all the time and upcode like crazy. And I know Oak Street Medical actually has some scribes who are specially trained in upcoding. I call them upcoding scribes, who sit there in the room with the doctor and the patient and just write down the diagnosis. So I think it's a little hard sometimes for people to understand, what upcoding is about. And I'm actually Medicare age, and so I kind of know, and some of the rest of you are too, is based on that poll, that when you get to a certain age, a lot of little stuff goes wrong. You're really lucky if it's just little stuff. And one little thing goes wrong with me is I'm a runner, and I used to run 6 miles a day, but now if I go more than 4 miles, man, my right knee really hurts. Okay, so I got to stop running about 3 or 4 miles. Okay, is that arthritis? Well, of course it is. It didn't happen 20 years ago, but does anybody really need to have that written down as a diagnosis to have knee arthritis? And I don't actually even think I've ever told my doctor this, right? But if I went to Oak Street Medical, they'd be writing down knee arthritis, because you can get more money for it. And it turns out that, my slightly gimpy knee is typical of other organs in aging bodies, that, your heart ventricle gets a little stiff. And if you want to overdiagnose it, you could call that early heart failure. Your pancreas gets a little tired. And if you wanted to, do a bunch of tests, you might say pre-diabetes. Certainly organs like prostates will often have, very tiny bits of tissue that look like cancer. They're never going to bother you in your life, but if you do very rigorously pursue all those things, you might be able to say, very early prostate cancer, we're just going to watch and wait. So what I was talking about with my knee is actually true of a lot of the organ systems in older people, that if you vigorously screen for and try to diagnose everything, you can come up with a very long list of diagnoses. And then, the doctors reassure your patients, but Steffi, you don't need to do anything about your knee, or, Joe, you don't need to do anything about this little bit of prostate cancer. It's probably never going to bother you. Or, your ventricle's a little stiff. We're calling it, it's just a touch of heart failure. Let's just watch it. So that's what they do, is they come up with a long list of diagnoses. And it's allowed them to make so much money, which they share. The primary care group gets part of it. The Medicare Advantage gets part of it. And that's why they can start talking about selling a business at $196,000 per human life. And this is a process that is very quickly going to destroy Medicare, right? If they keep upcoding, and then Medicare has to pay more and more and more in premiums, Medicare is going to very quickly run out of money, and we're going to keep hearing, there's no money for eyeglasses. There's no money to, take away that 20% copayment. Now, what are direct contracting entities? Well, only about 40% of Medicare folks choose to enroll in Medicare Advantage. They usually choose to do so because of those lower upfront costs. And, if you're really poor, frankly, $200 for a pair of eyeglasses sounds like a good deal, or lower copayments. Or they get forced into it. The public workers in New York City are all being forced into Medicare Advantage because their employer wants to do this. But 60% of people are not in Medicare Advantage, and the insurance industry is kind of saying, well, we want to make some money off of them too. So they persuaded the Trump administration to start this program called Direct Contracting Entities, or DCEs. It's partially suspended by Biden, but it's partially ongoing, and it has not been ended. It's just like a moratorium on parts of it right now. And what it does is, without even telling you you're in managed care, the federal government contracts with an insurance firm to be the middleman and manage your care. And so you're being enrolled without your consent, and the federal government is handing the money not to the doctors and hospitals, but through these middlemen who are then indirectly managing your care. And most of these middlemen are insurance firms. There are some other participants in this, but more than half of the folks who signed up to be the middlemen and these direct contracting entities are insurance firms. And it's been a total misnomer. It's got nothing to do with direct contracting. It's indirect contracting. They're sending the money through a managed care insurance plan rather than straight to the doctors and hospitals. So one of the things we need to be doing is to make sure these direct contracting entities are not really allowed to go forward, and that's stopped. One final thing, and this is just something when I became eligible for Medicare, they sent me this thing from the federal government, Medicare.gov, my government, saying you may be, and so it's a little hard to read, but you may be able to lower your out-of-pocket costs while getting extra benefits like vision, hearing, dental, prescription coverage. In fact, 4 out of 5 people will pay less than $50 a month. Why is the federal government advertising for private insurance? And, it was easier to understand in the Trump administration, but the Medicare Advantage and insurance industries have far too many allies within the Democratic Party as well. And we need to be holding the Democrats as well as the Republicans. We need to hold their feet to the fire and say, we need to build on and improve traditional Medicare, not privatize it and allow private insurers to extract tens of billions of dollars of profits out of the Medicare program while telling us there's no money there to improve Medicare or expand Medicaid. Okay, so I'm going to stop sharing.
Wow, thank you so much, Steffi and Diane, for those wonderful slides that try to explain this complex, mess that we have as our healthcare system. It's so hard to figure out what's going on because everything is just so confusing and unnecessarily complex. And also it's difficult because it could be cheaper for some people on the front end that don't have money, that they're not, knowing that it could be more expensive at the back end, or it might not be because they might stay healthy. So it just makes it even more confusing, unfortunately. And that's, I think, the point. They like keeping it confusing, the insurance companies, so that, they can keep their gravy train. They can keep making the money off of the people. And it's really a sad state of affairs. We have had an amazing chat going on, tons and tons of questions. Diane and Steffi, are you able to answer just a few questions? Okay, before we do that, I want to launch the last poll, Andy, poll 4. And you can read it because I don't know when it's going to go up.
It is up. So our final question is, at what age should Medicare start? 65, 60, 55, or birth?
Yes, and anyone who knows what I would answer the poll question as. I'm going to now turn it over to Megan Dunn, who is a pediatric nurse and lactation specialist in Charlotte, North Carolina, and she's going to ask a few of the questions. Megan?
Thanks so much. And the first question was, I have Medicare Advantage. What can I do to get off of the plan and get traditional Medicare? I'll ask, yeah, it looks like Steffi, you have a answer?
Yeah, it used to be that you could go back to traditional Medicare any month of the year. But that, I don't believe that's true anymore. I think you have to finish out the plan year before you go back to traditional Medicare. But you should be aware that the upfront costs are going to be higher. So if you can't afford that, then that could be a problem. Yeah.
And actually, there are other problems. Right now, it's October 15th starts the annual open enrollment period. And as Steffi said, you could then start your coverage in January. There are sometimes exceptions if you move and in other situations where you can switch mid-year. But the bigger issue is one that Thom had raised, which is that you may not be able to buy supplemental coverage depending on the state you live in. There are 4 states, New York included, Massachusetts, I think it's Connecticut and Vermont, where you can always buy Medicare supplemental insurance if you can afford it. But in other states, after your first year, when you only have the guaranteed right to buy Medigap when you first sign up for Part B, and then within the first year of being in Medicare Advantage, if you choose Medicare Advantage. So that's a problem because it's too financially risky to join traditional Medicare if you can't buy supplemental coverage because there's no cap on out-of-pocket costs.
Thank you. Speaking of the October 15th deadline, we had another question. Where can we get good information about Medigap coverage before October 15th besides the really thick booklet?
You have, I think, between October 15th and December 7th to switch. So you have a little bit of time. You should be able to call your state health insurance assistance program for free help. Also, I think your state health department has information on Medigap.
Thank you. We had another question about what is the best Medicare Advantage plan? Do we know?
We have no clue.
Yeah, I don't know. I mean, I think the thing I would recommend is to ask your friends if they've got a plan that allows them to see the doctors they want. You can ask if you have doctors you feel you really want to see. You ought to ask them which plans they participate in. But as Diane was pointing out, there's no guarantee your doctor can be participating now, and 6 months from now, the Medicare Advantage plan can throw your doctor out if they decide she's, not making enough money for them. So, but that is actually what I recommend. I don't, I'm actually, like several other panelists, I'm a health policy expert, but I can't look at an insurance company booklet and tell you what's a good plan and what's not. And I really have trouble looking just at the list of providers because I know it can change, but that's a little more reliable if there's a provider you need. You just sign up with that.
The only thing I'd add here is that most likely the nonprofit Medicare Advantage plan is going to be better than the for-profit ones. So the Kaiser, Intermountain, Geisinger plans are most likely better.
Thanks. We had a question about upcoding. Does upcoding stay with a person if they move from one Advantage program or plan to another Medicare Advantage plan?
Upcoding doesn't stay with the person. It stays in their record, but it doesn't. Upcoding is for the benefit of the Medicare Advantage plan exclusively. The more diagnoses they can assign to a patient, the more money they're paid. From the patients, excuse me?
The diagnoses won't follow a patient from.
It will, but I don't think it will affect the patient in any way.
Yeah, I mean, it's mostly not harmful for you. Sometimes this stuff sounds scary, like they tell you have a little touch of heart failure when you don't. You have a little touch of diabetes when you don't really have it. That can be scary, but it's not usually that harmful. It's mostly harmful to Medicare, to the taxpayers, because it's cheating and it's getting extra money to come in. The actual payment to the Medicare Advantage plan, so it's HCC, whatever, that's supposed to be based on the diagnoses that were actually treated in the last year. It's not supposed to be based on something that happened, 7 years ago and is not being treated. But part of upcoding is doing a little bit of at least counseling or whatever related to older diagnoses, and then you can include them. So no, it doesn't even follow you really year to year. It's a 1 year thing, other than it's in your record and it's very easy for other people to copy it down. See, it's there.
Thanks. If I have time for another question, we have some North Carolina state employees on the call, and they have state employee health insurance through Humana, and their paperwork says it's Medicare Advantage. Do employees in this situation even have a choice between a Medicare Advantage plan and another plan?
Well, I can tell you the situation in New York State, which is the public workers in New York City were all put in Medicare Advantage, and they weren't offered a choice. The unions considered going on strike about it. They didn't in the end. My local actually wanted to go on strike, but the overall union didn't. But or we went to protest it, at least try to bargain on it. So if you're in a union, if you're lucky enough to be in a union, that's actually the way to approach this, is to try to get the union to intercede if you would prefer to have a, if you be more comfortable, which I would be. I am personally with traditional Medicare.
But Steffi, my understanding is you are forced in, you're signed up, but you are allowed to opt out. Yes.
Usually what that would mean is that you would lose your employer's giving you Medigap. Okay. Right. So yes, I actually am not in the New York City plan. I have access to healthcare through Harvard University, where I'm a retiree, an early retiree from Harvard. However, if I had to get my insurance through the city of New York, I would forfeit my Medigap coverage by leaving the plan and going into traditional Medicare. So yeah, so for these Humana enrollees, I think they always have the right to opt out of their retiree plan. But the problem, as Steffi said, is that then they have to spend their own money on supplemental coverage in traditional Medicare, which is, from my perspective, well worth it if you can afford it, because then you have the control over your care that you really want and the access to care without obstacles that you really need if you get sick.
Thanks. Another participant wanted to know if there is any assurance that their Medicare Advantage plan that they have right now that seems to be working for them won't change next year.
No assurance. In fact, I think the Kaiser Family Foundation has found that plans often change dramatically, especially their cost structure from one year to the next. And most people don't pay attention. And so they stick with the plan because that's the easiest thing to do when they could save money by switching to another plan. So it's always good to take a really hard look at what you'll be getting in the following year and make a new choice from one year to the next, which is burdensome and stressful and anxiety provoking and shouldn't be necessary, but it is.
Thank you. There was a question from another participant who wanted to know if, because all of this is so complex, is there anywhere where there is a side-by-side comparison of Medicare Advantage and Medicare that can kind of show people what the differences are, so that something that's easy to share and explain to other people?
I have two documents I've written on that. One that talks about the 4 key differences, which are sort of more macro, and then that one that I think goes into like 10. So I can share those with you guys, and I'm happy to have you send them out.
Thanks. That would be great.
All right. Is there maybe, well, let's stop it there because it's already very, very late. And Steffi and Diane have been very generous with their time. Thank you both so much, not just for coming and participating today, but for all the work that you are both doing and have done for so long to try and get us a better healthcare system that works for all of us, that will save us money, that will help dismantle racial health disparities, that will actually not fail us in the middle of public health crisis. Thank you, thank you, thank you for all your work and for your generosity with your time tonight. Thanks. So we are going to get the last poll results. Andy?
Yes. So 73% of our participants believe Medicare should start at birth, and 10% think 65, 8% 60, and 8% 55, but majority think birth.
Wonderful. Yes, well, like I said, birth for me. So Sherry, I see that you have your hand raised, but I want to just finish out the program, and then if people want to hang on because I know you have a wealth of knowledge in this, but it's been a very long evening. So I just want to thank everyone again for tuning in, for listening, for asking such great questions, for having so much interaction in the chat about this. Again, we have this overly complex system. Medicare Advantage plans are just one of the complexities in this system. And the bigger picture is for folks like myself who are advocates for a single payer system. We know that the more and more the private insurance companies dig their claws into these policies, the harder and harder it's going to be to get them out of it. If we ever actually want to get improved Medicare for all system in this country that would cost us less and get better care for our folks. And no one would ever go broke because they got sick or had an accident, which happens all the time in our country, in the richest country on earth. So I want to just turn it over to Reverend Floyd Wicker from Fayetteville, who's going to just close us out with a few words of inspiration. He's a member of our Medicare for All Coalition, and also a part of the Faith Caucus of the North Carolina Medicare for All Coalition. Reverend Wicker.
Good evening. I hope everyone is doing well. This has been a phenomenal program. First, I'd like to just say thank you to all of the participants and panelists who have shared with us this evening. I would also like to thank you, the people in our virtual audience, for your participation as well. Because in truth, all of us are in this glorious struggle together. And tonight I would like to say that I am happy to join forces with the North Carolina Medicare for All Coalition as we do our part in this state to make universal health care a reality for all. Tonight, I am reminded of an African proverb which states, if you want to go fast, go alone. But if you want to go far, go with others. As we all know, sometimes going with others can be an arduous task. Going with others can be difficult and very challenging on a variety of levels. But in order for us to go far in accomplishing our ultimate goal of universal health care, it's going to take all of us, and I mean all of us, working together. It's going to take all of us growing together. It's going to take all of us learning to appreciate and value the beautiful mosaic of our cultural and even our political differences. In this movement, we are going to have to be radically inclusive, radically loving, and definitely driven by our desire to end unnecessary human suffering. We need to invite as many people to this movement as we can. So tonight, my call to action is a little different. In addition to calling your local, state, and congressional representatives and asking them to sign on to universal health care, in addition to us staging another social media tweet storm or a massive direct action, in addition, I implore you, go next door, talk to your neighbors, talk to your coworkers, your friends, and your relatives. Do as we did just a few weeks ago. Go to your local flea market In other words, we have to get out there with the people and talk to them about the good news of health care for all. Health care for the single mother, health care for the entrepreneur, health care for the returning citizen, health care for the 140 million poor and low-wage workers nationwide. We are blessed. Many of us are blessed on this call tonight because we do have health care. But in closing, I want to use a common refrain from my faith tradition. And it simply says, we've come this far by faith, leaning on the Lord. Friends, I believe the God of the universe is with us. So my call to action tonight for you is, let us all go forth in love and in service. Thank you, and may the God of the universe be with you and be with us in this journey. God bless you.
Thank you so much, Reverend Wicker, for those wonderful, wonderful words. I am going to let most folks go, but I do want to give Sherry, because she obviously has a lot of information, some time to talk. But if folks have to go, I completely understand. Thank you again for joining us. Andy, you can make me the host and you can sign off. It's been a super long day. Thank you everyone again, and we'll send out links to the recording of this to folks. You can find it on the North Carolina Justice Center Facebook page, the North Carolina Medicare for All Coalition Facebook page. You'll be able to watch it again or send it to other folks. And again, there is this $3.5 trillion reconciliation package that is being discussed right now. People are already talking about cutting it, but there's nothing wrong with us advocating for the full enchilada, all of it. And we have the money for all of it. We, you know, like what Senator Turner said at the beginning, we have endless amounts of money for the defense budget. Why can't we have endless amounts of money to actually uplift the American people? We can have a different world. It's really up to us to fight for it. So thank you very much, and good night to most of you.